Welcome to our series. My name is Cindy Kenna, and I'm going to be your moderator this morning. Before we begin, I'd like to share a little bit of the series, about the series that you're attending today. The Lincoln Hills Foundation created the Wise Aging series to offer practical and straightforward guidance for planning as we grow older. Aging brings both subtle and sudden challenges, and this series is designed to help residents understand those challenges and prepare before crisis occurs. Each month, we'll explore topics ranging from cognitive to physical changes to medical, financial, daily life, social, and emotional changes that affect us all. Our goal is to give you clear information, useful tools, and the confidence to plan ahead. We have comment cards that we've handed out, and we hope you'll fill them out. If there are topics you would like to see as a presentation, please let us know. The series is designed for all of us, and your suggestions will help us bring in the right experts. On the back of the comment cards, you'll find a little blurb about the Lincoln Hills Foundation, if you'd like to learn a little bit more about the foundation. You've also received a slip of paper that you can provide your email address on. If you'd like to receive advance notices of these sessions that we're doing. And it'll also tell you the URL for our videos that we're recording. If you don't happen to see our advertising, email ensures that you will still see every update for upcoming presentations. We are videotaping this particular presentation today, and we will make it available on our website. As you leave, you can drop your comment cards and your email addresses if you want to leave them in baskets that we've left outside by the doors. A little bit of housekeeping. We have emergency exits on each side here, and the two doors that you came in the back. Please silence your cell phones and any other devices that could interrupt the presentation today. And restrooms are out the back door and to your right.
Cindy, I'm not sure I've got your right slide up, which...
I keep forgetting. Okay. Go ahead and change the slide to the third slide. Okay, that one. Thank you. Okay, so just briefly, I wanted to highlight two more presentations that are coming in August and September. Navigating the Medicare maze and what to expect in 2027 is coming up in 2 weeks on August 7th. And then we'll also have one on cognitive aging in September. And we have flyers outside on the table, or we'll hand you one as you leave to give you more details and the dates and times of those presentations. Okay, so let's turn to today's program. The program is Medications That Deserve a Second Look. We are very fortunate to have Dr. Bloom and Daryl Lance, pharmacist, with us today. They will be discussing medication safety and why it becomes increasingly important as we age, how our bodies respond differently to medication over time, what the risks and the potential side effects are, and what safer alternatives are available. Mark Bloom, MD, is a clinical professor of medicine at the University of California, Davis School of Medicine. He practiced hospice and palliative medicine and internal medicine at Kaiser Permanente in Sacramento for 30 years, and then he was the hospice medical director at Bristol Hospice in Roseville for another 10. Dr. Bloom has lectured locally and nationally on topics related to the care of end of life. He has been retired from active practice for 8 years and has been a resident of Sun City, Lincoln Hills for 5. Dr. Bloom is board certified in internal medicine and also in hospice and palliative medicine. Daryl Lance is a pharmacist with extensive experience with oncology and clinical operations. He is a board certified oncology pharmacist with extensive experience in clinical practice, medical affairs, and oncology pharmacy leadership. A graduate of the University of Pacific Doctor of Pharmacy program, he completed his residency at the California Pacific Medical Center in San Francisco. He has served in key roles at Merck Pharmaceuticals, UC Davis Medical Center, the Veterans Administration at Mather, and Kaiser Permanente, where he led oncology pharmacy services, clinical operations, and hospice pharmacy care. His career is focused on medication safety, cancer treatment optimization, and ensuring that complex therapies are used appropriately and effectively. Please welcome Dr. Bloom and Daryl Lance, pharmacist.
Thank you, Cindy, for the kind introduction and giving our background. Mark and I have worked together for a long time, and we've known each other for quite some time too. But hopefully, we'll get to some topics that you might be knowing a little bit more about. And so we're going to kind of go over quite a few different things, and mainly just high risk medications that you really should look for and things to really think about. And we're going to be piggybacking on, I'm going to cover a few topics, and Mark's going to cover a few topics, and then what we're going to do is open it up for questions after we get done. So why are older adults more sensitive? They're more sensitive for a lot of different reasons, and I'm going to go over those in just a second. There's 8 high-risk drug classes we're going to go over: examples, risk, safer alternatives, key takeaways, and then questions. Next slide. So why do we have changes? So we have slower absorption. The gut just doesn't work so well. And a lot of times people, as they get older, they say, well, I have dinner, but I just can't eat as much anymore. In the same way with medications, things kind of slow down and they don't get absorbed quite as well. Changes in body composition, people have less water content and more fat content. Increased CNS or central nervous system sensitivity. So there is a blood-brain barrier between the rest of the body and the brain. And over time, that kind of starts to break down a little bit. And so some medications that you were taking in your 20s, 30s, 40s work one way, but as you get older, you're a little bit more sensitive to. And that's some of the reasons why some of these things happen. Next slide, please. So polypharmacy in adults. So why am I taking too many medications? So my mom, when she turned around about 82 or so, I was looking at her medication list, and she was taking like 18 different things. So that gets to be very problematic for a lot of reasons. One is trying to keep them on schedule, and two, another problem is some of these things interact. So what's that mean? So taking 5, 10 or more medications, higher risk of interactions. So like as an example, when you're taking blood thinners, or if you're taking blood thinners and you're also taking like aspirin, or you're taking ibuprofen or Motrin, those interact and actually can increase your risk of bleeding. Other things like statins, if you're taking clarithromycin for like a upper respiratory tract infection, that can interact and actually makes the statins actually work a little bit more and maybe cause more muscle pain. And then you have antagonistic, where one drug actually inhibits another drug, and so the drug doesn't work as well. Another thing that happens is multiple prescribers. You go to this doctor and they say, well, I'm going to put you on this, and it's a drug very similar to what you're already on. So multiple prescribers, a lot of times they don't know what you're taking. Prescribing cascade, side effects of drug is misinterpreted as a new problem. So you get a new drug and you're getting drowsy all of a sudden, or you're getting more constipated. And it's probably from the drug, not so much that you're developing a new problem. Addition of nutritional supplements, herbal medications. A lot of herbal medications are actually, they can be, one, contraindicated, and two, they can actually make things worse with some of the things. And I'm going to cover a little bit about that. Next slide. So how do we mitigate strategy? So deprescribing. So looking at the medications and making sure that the medications you are taking are actually working, not that you're just taking them. Medication reconciliation. So along with any herbal supplements or nutritional supplements, you should check with your physician to make sure that those are okay. Keeping a master list of all prescriptions, over-the-counters, and any supplements. And one of the things that's really important is to go to the same pharmacy, because they have those records right there. And if you go to CVS, you go to Walgreens, all of those pharma or Kaiser, all those pharmacies, no matter what pharmacy, they're looking at the same profile. So as long as you stay in that system, they're seeing it. But if you go to a community pharmacy, or if you go to, and then you go to CVS and you're getting things at different pharmacies, sometimes they don't talk to each other. Next slide. So I'm going to go over benzodiazepines, and this is a huge class of drugs. You probably heard of a lot of them: Valium, Ativan, Xanax, Klonopin, Restoril. They're used for sleep, anxiety, kind of nervousness, sometimes essential tremor. So what are the risks? Well, you can get sedation, you can get delirium, cognitive impairment, and older adults are definitely more sensitive to this. They also can cause dependence. So there was a book that was written back, I think it was in 1970, on Valium. After Valium came out, this lady had taken it, and the book's title is "I'm Dancing as Fast as I Can," and she became dependent on that. And a lot of times, if you're taking these drugs regularly, it's very difficult to come off of them. So, make sure that you're taking it for a reason. My mother-in-law was taking Restoril for sleep, and if she didn't have it, she became very manic about it. And if the pharmacy was out of it or she couldn't get it, she would get very agitated and nervous because it was really, she was dependent upon it. So you have to be careful about that. So why are they so risky? Next slide. Slower hepatic clearance. As you get older, your liver doesn't work quite as well. Accumulation of metabolites like Valium, it has a half-life of 20 hours, which if you look at Valium, it takes 5 half-lives to get out of your system. And so that's really a long time. So 5 times 20, so like 100 hours, up to 100 hours. But Ativan only has like a 4-hour half-life, and it breaks down into inactive metabolites. And so after 4 to 6 hours, it's pretty much out of your system. It can cause increased CNS depression or central nervous system depression. And you'd have drug-drug interactions, and alcohol can actually exacerbate some of these sedative effects. Also, herbal things like valerian root, chamomile, St. John's wort, that can actually exacerbate the sedation from these drugs. Over-the-counter drugs, things like Benadryl, chlortrimeton, that can exacerbate the sedative effects. Hey, Mark, I think you're up. Next slide.
Thank you, Daryl. So start with one of my hobbies is wildlife photography, and especially underwater photography. So this is an example, and I don't want anybody to say anything yet, but I do have a $5 gift card to Starbucks. And later on, when we come back to this, the first person who can tell me what critter this is gets a free Starbucks. So don't call it out now, please. Okay, let's go on. So I'm going to talk about the so-called Z drugs. These are, Daryl just told you about benzodiazepines. These are the non-benzodiazepine sedatives, which are promoted as safer for sleep and sedation than the benzodiazepines themselves. But safer doesn't mean totally safe. The risk is less, but it's not zero. Common drugs amongst the Z drugs are sulpidem, which is Ambien, Zelepion, which is Sonata, and Zipicione, which is Lunesta. Probably some of you are familiar with these drugs. One of the major risks, albeit not too common, are complex sleep disorders. And folks using these drugs have been reported to do sleepwalking, sleep driving. Sleep driving patients are actually get into their car, out the garage, driving around the neighborhood while they are technically asleep. Obviously, the risk there is immense. People can eat while they're asleep on these drugs, so they need to be used with extreme caution, and especially in our age group, which includes me. Somebody taking one of the Z drugs has greater than double the baseline risk of falls and resultant hip fractures, vertebral fractures, wrist fractures, none of which we want to have. There's a 5 times increased risk of delirium. Delirium is an acute confusional state. Also increased risk of motor vehicle accidents and other injuries. Cognitive effects of the Z drugs include memory loss, disorientation, and confusion. If you are going to use any of these drugs for sleep, and they're prescribed, the take-home message here is lowest dose for the shortest time possible. If you limit it to occasional use for insomnia, once a week, once a month, the safety profile is reasonably safe. Again, not totally safe, but reasonably safe. Where folks get into trouble is when they're taking these every night or nearly every night. That's where the problems really mount up. Next slide, please. Next class of drugs to talk about is anticholinergic medicines. These are extremely common. Many of us are taking these and not even being aware of it. The most commonly used over-the-counter anticholinergic drug is diphenhydramine. The common brand name is Benadryl. However, it's very important to be aware that diphenhydramine is included in many commonly used over-the-counter drugs. Probably the most common one is Tylenol PM. Tylenol PM is acetaminophen and diphenhydramine. This diphenhydramine is also included in some over-the-counter drugs that are used for upper respiratory infections like Robitussin, Theraflu, Sudafed, Mucinex. And all of these products have multiple different brands and formulations. So read labels. If you go to the drugstore, you need something for cold or allergy, look not just at the brand name that it's Tylenol PM or this Robitussin DM, but look at the label and look to see if there's diphenhydramine. And those are the ones that you really want to avoid. Anticholinergic meds also, there's also numerous prescription drugs that have anticholinergic activity. This includes ditropan or oxybutynin, which is often used for irritable bladder symptoms. Tricyclic antidepressants, not used nearly as much now as they were years ago. They've been largely replaced by other antidepressants, which have better safety profiles. Flexeril, which is often prescribed for muscle spasm, back pain, things like that. Phenergan, sometimes prescribed for nausea, also has anticholinergic activity. I'm not going to get into the biopharmacology of anticholinergics. It's rather arcane, but suffice it to say that these drugs have risk for confusion, urinary retention, constipation, dry mouth, blurred vision, and this is just the more common side effects. There are others as well. So drugs that we should be avoiding. Next, please. There's also a condition of anticholinergic excess when these drugs build up. And if you're taking multiple anticholinergics, so you're having an allergy problem and you're using Benadryl and you're using Elavil for nerve pain, they're both anticholinergic. And that's just one example. But the effects, the side effects are additive. There's a link for risk of dementia and other cognitive changes when using anticholinergics. Next, please. And back to Daryl.
Thank you, Dr. Blum. So everybody heard why about narcotics. And narcotics are they're used quite a bit. And we're going to go over that in a case study in a little bit. So some of the things that they have is morphine. Morphine comes in a short-acting and a long-acting product. It comes in a pill form, it comes in a liquid form, comes in an IV form. Oxycodone, you probably heard a lot about that over the years as far as abuses of oxycodone. Percocet, OxyContin, hydrocodone, Vicodin, Norco, hydromorphone dilaudid, which is a very potent narcotic, and then tramadol, which is Ultram, which is still it's not quite an opioid per se, but it still is listed in that same kind of class because it works on that receptor. So what are the risks? Respiratory depression. So if you're overprescribed these or you take too many of them, especially in the short term, respiratory depression can be really quite a problem. And that's a lot of times if you see these overdoses where people are taking fentanyl on the street, they're not used to these large doses. It causes severe respiratory depression, and actually they can die from that. Sedation is very common. Constipation. Whenever you take any of these narcotics, you really need to take a laxative medication too, either Senokot or Bisacodil, something like that. They can cause falls. People get very confused sometimes with these things as they take them more often, or if you forget and you take a double dose. Dependence and addiction. So if you take these, and it can happen within 2 or 3 weeks where you actually get dependent on these things, if you go off of it, you feel like you still need it. And we have treated a lot of patients that, their cancer pain got better, but they were still dependent on these drugs. And so we had to wean them off for a long period of time. Sometimes it takes weeks to months to slowly wean them off of that. And so that's really important too. So tramadol risk includes seizures, serotonin syndrome, severe hyponatremia, which is a low sodium. And low sodium, if you have an acute low sodium, which means your sodium level drops pretty rapidly, and this can cause that, tramadol can cause that. What happens is you can get confusion, you can actually pass out, you can have falls with that, and it's especially in older women. So you use the lowest effective dose, and you monitor these patients really closely. Another kind of caveat to this is another drug called methadone, which isn't used quite so much. It's usually used in a narcotic treatment setting, but you might see it in patients that have really bad nerve pain. And the caveat to that is with methadone, it has a huge, long half-life. And so you start very slowly. So if you ever see that drug. So next slide. So non-steroidal anti-inflammatory drugs. Now we all use this, especially, as we're younger. If you pull a muscle, you're out playing sports, you're out for a run, you're cleaning the house, and you pull a muscle, and so you'll take a Motrin, Naproxen, Voltaren, or diclofenac, indomethacin. You don't see indomethacin too much anymore. It's rarely used. Meloxicam or Mobic, which occasionally you'll see, and then Relafin. But the more common ones that you buy over the counter or ibuprofen and naproxen. And, there's risk to these things, and there's actually quite a bit of risk. As you get older, you get more sensitive to these risks. Next slide, please. So you can get some GI mucosal damage. You can get bleeding, especially on really common use or chronic use of these things. I've seen a lot of professional athletes. They have a lot of, muscle pain or knee pain or some kind of pain, and they'll take a lot of these things chronically over the time. And so two things that happens to them: one, they can get some GI bleeding. Two, it can actually affect your kidneys where they don't work as well, and so you get reduced kidney function. The other thing is you can get increase in bruising. So if you are using these and you notice you're bruising more, it's actually because of this particular drug. And then the other thing too, especially out in the sun, if anybody's out doing a lot of outdoor things, it actually can increase your sensitivity to getting a sunburn or like a rash type of thing. And I've seen that quite a bit, actually. Reduced kidney perfusion and function, that can be a huge problem, especially if somebody has hypertension. It actually worsen hypertension because when the kidney doesn't work as well, it secretes a chemical which actually causes the blood pressure to go up because it doesn't think that you have enough blood pressure. And that can lead in somebody to acute heart failure. So non-steroidal anti-inflammatories are really useful, but you have to be very careful with them. And also, if you're on a blood thinner, these things can actually worsen the clotting or the bleeding of this. So if you're on a blood thinner and you start taking these things, you might see increased bruising, and if you do, you need to stop that. So a better alternative is take something like Tylenol. Let's see. Oh, the other thing is some herbal medication. So avoid ginseng, high doses of vitamin E, which can cause increased bleeding. Anybody that's taking like a lot of garlic capsules, that can cause it. Willow bark tea probably isn't that big a thing because it's a tea, but willow bark is a precursor to aspirin. So that can work the same way as far as affecting bleeding. Okay, Mark, for antipsychotics. Next slide.
So next class of drugs that we'll talk about are the antipsychotics. And you can see the common ones here: Haldol, Risperdal, Seroquel, Zyprexa, Abilify. And this is just some of the more common examples. There's probably at least a dozen more that are available. The risk of antipsychotics, stroke, increased mortality in dementia. That's important. Dementia patients are prone to agitated behaviors, and they can be very difficult to control. I suspect that some of you here have had loved ones who've gone through this with advanced dementia. And there's definitely an increased mortality risk in using antipsychotics in patients with dementia. Unfortunately, sometimes they're the only thing that works to control disturbing behaviors. Now, as an aside, I just read a paper yesterday about a study in Europe where they used a combination of THC and CBD, the two active products in cannabis, in patients with dementia and agitation. And in a controlled double-blind study, they found that the THC-CBD combination was quite effective in treating agitated behaviors in dementia without increase in side effects. So I say this is fresh off the press as of this week. Other risks of antipsychotics are sedation, Orthostatic hypotension, really a problem in the elderly. That orthostatic hypotension means you stand up, your blood pressure drops. That places you at risk of fall and injuries. Seems to be a recurring theme in this presentation is falls and injuries in our age group with a lot of these drugs. And falls and injuries in our age group can be devastating. Next, please. So, for using antipsychotics in dementia, sometimes the only thing that will calm aggressive and disturbing behaviors, notwithstanding this new report out this week, they should be used only when non-pharmacologic methods have failed. It's not the first thing one would do for a patient with dementia who's having disturbing behaviors. That's the last thing. Other things that can be done are talking, calming, music, therapy, trying to get the patient to calm down. If you're using an antipsychotic in a patient with agitated behaviors, you want to reassess frequently and use the lowest effective dose and continually reevaluate is what you're doing being effective and not causing side effects. Next, please. Back to Daryl.
So now I'm going to talk about long-acting sulfonylureas. So these are drugs that are used for diabetes. In the elderly population, glyburide micronase diabetic, they're really long-acting, and in our population, yeah, they can be really long-acting, much more than we expect. So you can get prolonged severe hypoglycemia. So what that means is it might take a long time for this drug to wear off, and your blood sugar is going to be super low. Also, this is worse than reduced kidney function. So that can cause falls and confusion. Like Mark said, this is a recurring theme. And a lot of times people will have falls and they think it's maybe because of their unsteadiness or, they're up too fast, but sometimes it may be due to the drugs. So what are some safer alternatives? So glipizide or glucontrol, it's a short-acting one. So if you're having a problem, it's not going to last as long. So you're able to control that better. Metformin, DPP-4 inhibitors or gliptins, Januvia, Tradjenta, GLP-1 agonists. So everybody has seen that. That's made a lot of the pharmaceutical companies a lot of money, but it's actually helped a lot of people too because they work they tend to be pretty tolerated. Where that's going to go in the future, we're not sure if it's going to be, you're going to be on it forever. Merck, who I used to work for, they just came out with an oral one, which that's huge because all the other ones were injectable. So that's going to be, so using those is actually better than using the long-acting sulfonylureas. Not that they aren't helpful, but these other ones have a little safer profile. So next slide, we're going to go over some safer medication alternatives. So for anxiety, we used in the hospice population, Mark and I, we've used Buspar or Buspirone pretty effectively, and it actually works pretty well, and it doesn't cause a huge amount of side effects. It was actually, especially in those patients that you hear, or you might even know somebody that is afraid to go out of the house, and they were worried about this, worried about that, and so a lot of times we'll put them on something like Buspar, which is better than putting them on like a Valium type of derivative. For sleep, melatonin is pretty helpful. Pain, Tylenol, topical non-steroidal. So if you really have like knee pain, a topical product is better than taking an oral product. It still can be absorbed to some extent, and if you're on blood thinners, you can get some more bruising, but it's extremely rare and not as much as if you're taking those kinds of things orally. Whenever possible, choose medication with lower risk profile. There's no such thing as a drug with zero potential side effects. And that goes the same with herbal products. A lot of these herbal products do also have side effects. You need to balance the benefits of the risk. And so if you're taking something and you're having problems with it, talk to your doctor, talk to the pharmacist, see if there's another alternative or if you really need to be taking this drug. And back to herbal, so even though it's a natural product, it doesn't necessarily mean it's safe. So you have to remember that. So anytime you take anything, any of these kinds of things, it can be a problem. And back to Mark. Next slide.
So I want to talk about use of aspirin for prevention of cardiovascular events such as heart attack and stroke. And there's really breaks down into two categories. First is primary prevention. This is somebody who has no history of a prior heart attack, a stroke, a TIA, angina. This is so aspirin use in this group for primary prevention is no longer recommended for folks over the age of 60. It used to be, going back 10, 20 years ago, a lot of folks in our age group who had not had previous cardiovascular events were recommended to take a daily dose of baby aspirin. That's no longer the case, and the reason is this. There is a reduced incidence of events, 11% reduction of non-fatal heart attacks, an 18% reduction of non-fatal non-fatal stroke. But use of aspirin does not reduce cardiovascular or all-cause mortality. So, yes, less heart attacks, yes, less strokes, but the death rate is not reduced. And on the other hand, there's a 58% increase in episodes of major GI bleeding, not just a little bit of blood in your stool, but I'm talking about a major GI bleed, which requires hospitalization, blood transfusions, endoscopy, and can be fatal. And 31% increase in episodes of bleeding in the brain. Bleeding in the brain is the most devastating form of a stroke. Most strokes are due to blood clots in the brain, and that's what aspirin is designed to prevent. And while that's not good, it's not nearly as bad as having bleeding in the brain. Next slide. Secondary prevention is a different story. And so for those of you who are on aspirin for secondary prevention, I do not want to suggest at all that you shouldn't be doing it. So secondary prevention is somebody who does have a prior history of a heart attack, a stroke, a TIA, or angina. And if this includes you and your doctor has recommended aspirin, that certainly is in keeping with the current recommendations. It's still strongly recommended, as opposed to primary prevention where there is no reduction in mortality. In secondary prevention, there's a 19 to 25% reduction in non-fatal heart attack, stroke, and most importantly, all-cause mortality. So that's an important benefit. And in this setting of secondary prevention, the number of vascular events and deaths prevented significantly exceeds the number of serious bleeding episodes. So two very different scenarios. Primary prevention, not recommended. Secondary prevention, strongly recommended. Next, please. And back to Daryl.
And now we're going to go over a little bit of a case study. It's kind of something that we all can kind of relate to. We have a 75-year-old male with insomnia, hay fever, irritable bladder syndrome, The current medications, which is only two, zolpidem, Ambien, 5 milligrams at bedtime for sleep, and oxybutynin or ditropan, 5 milligrams 3 times a day for urinary urgency. So in the springtime, especially around here, that's when people's allergies get ramped up, and his did. He started using over-the-counter diphenhydramine or Benadryl, 25 milligrams 3 times a day as needed for sneezing and nasal congestion. 2 days ago, he was the driver in a single vehicle auto accident, colliding with a pole, and suffered a vertebral compression fracture. The ER physician prescribed acetaminophen hydrocodone, which is a narcotic, and Tylenol. 325, 5 milligrams every 4 to 6 hours for back pain, and he was discharged home. So now he's very sleepy, confused at times, having difficulty urinating, and he hasn't had a bowel movement for since the day prior to the auto accident. And these narcotics are pretty notorious for causing a decrease in or more constipation, and so you really have to watch out for that. And constipation, as we get older, gets even worse too, because we're either not drinking more or we're on medications that can actually exacerbate that. Next slide, please. So drug side effects, so diphenhydramine and zolpidem taken together can cause extreme and prolonged drowsiness, loss of balance, confusion, possibly resulting in accidents. So a lot of times you might feel a little bit more foggy the next day, or a lot more foggy. This may have led to the auto accident. Adding hydrocodone will further exacerbate the sedation. Hydrocodone and oxybutynin either can cause constipation, but both of them together can cause really severe constipation. Oxybutynin and diphenhydramine can cause urinary retention, possibly necessitating a bladder catheter, and nobody wants that. Risk is increased significantly using combination. Also, you have a risk of confusion, delirium, especially if used together. All these adverse reactions are much more common in the elderly. Next slide, please. So the key takeaways: older adults have increased drug sensitivity, 8 drug classes we just went over. Regular medication review is essential. So anytime you change anything, you add something, make sure your physician knows about it. Deprescribing improves safety. So looking at all the meds, maybe you have duplicates. You might have drugs that are very similar. Thoughtful prescribing can dramatically reduce harm. Next slide, please. Back to Mark.
Okay, so it's Starbucks time. Who knows what this critter is? Lionfish. Absolutely right. We have a winner. Congratulations. Can I have the next slide, please? So this guy is the known as the common lionfish. His scientific name is Pterosis volitans, about 12 to 15 inches long, native to the eastern stretches of the Indo-Pacific around Philippines, Indonesia, Papua New Guinea, Micronesia, in that area. These the business end of the lionfish is these spines here that come off the dorsal aspect of the fish. They are used for defense. If you get stung by a lionfish, you will be having a bad day. They're very painful, but rarely fatal. The nice part about it is, since these guys have great defenses, they're very photogenic. Most tropical fish are very photo shy, and when you swim up to them, you get a lot of butt shots as they swim away. But because the lionfish knows that he's pretty well protected, you can come up with, within as in this picture I took, within a few feet of them, and they just hang out and don't, they don't bother you, you don't bother them. They hunt by cornering their prey, like small reef fish and crustaceans, with their large pectoral fins. This guy here, and then they just gulp them down. The sad part is that they've become invasive in the Caribbean and the Gulf of Mexico and up the southern coast of Carolinas and Florida. They were released from, it's thought that they were released from an aquarium in the Atlantic in the 1980s. Because they're not native to this part of the world, they have few natural predators. And as a result, where they've established themselves on reefs, they have devastated the local endemic tropical reef populations. Fishing is encouraged, and they actually now have tournaments where folks go out and are awarded prizes for whoever can bag the most lionfish. Next, please. And here's a bonus question. So this is the Christmas tree worm. And this is actually a worm that embeds itself on coral heads. And I show this because besides being an interesting critter, who remembers the movie Avatar? Avatar. James Cameron, the director and creator of Avatar, is, like me, an enthusiastic diver. And if you think back to the movie, there is a scene where the characters are sort of running through a forest, and on the tree limbs, there are structures like this that project up off the top of the tree limb. And Cameron acknowledges that the Christmas tree worm, which she had seen diving, was the inspiration for this scene in Avatar. Mm-hmm. So I think this, yeah. So now we're time for questions. And before we do that, I'm going to tell a little story. So there's Professor Johnson, who gives the same lecture every week, travels around with his chauffeur, James, to drive him to the lecture. And after doing this for a year or two, the professor says to James, you know, you've heard this lecture so many times, I bet you could deliver it just as well as I could. James says, you know, Professor, I think you're right. So the next time that Professor Johnson is invited to speak, they switch places. James puts on the three-piece suit, and Professor Johnson puts on the chauffeur's uniform and sits at the back of the theater. And it goes beautifully. James does the lecture, the slides, the anecdotes, the jokes. It comes off perfectly, but what they didn't anticipate was questions at the end of the lecture.
Yeah.
So somebody raises their hand, asks James a question. He's puzzled for only a second, but being a quick thinker, he says, you know, that question you asked is so simple that my chauffeur, James, sitting at the back of the room, can answer it. So now Daryl and I will answer questions, and we don't have a chauffeur to answer for us. So, and do we have a roving microphone, Cindy?
Yes.
And since this is being recorded, we will repeat the questions.
I take aspirin, and I've been diagnosed with mild case of Alzheimer's. And I can't do the flow of the meds, so I'm having to take pills. My question is, and the reason I can't take it is because I have 6 minor brain bleeds. I take aspirin to reduce the stroke and the heart side. I'm in the catch-22. Infusions. I'm sorry. Yeah.
So, interesting question. So the question is, gentleman with early stage Alzheimer's and some bleeds in his brain, probably seen on MRI, I would imagine.
CAT scan.
CAT scan. Okay. Should he be taking aspirin? This really becomes a risk-benefit calculation. If he's had previous brain bleeds, that would not come under the category of secondary prevention. Secondary prevention for prior stroke would be thrombotic strokes, blood clots in the brain. So I would say this would be a good question to ask your physician, since we're here talking, but we're not treating you. But this would be a good question to say to your physician, I've had these previous bleeds, but have I had blood clots in my, did the MRI or CT show blood clots in the brain? And if not, is this something which is beneficial to me? So always ask your doc. Next one.
I don't.
Oh, it's okay. I'll repeat the question. Go ahead.
I
I'll repeat the question for the recorder. Go ahead.
Better. Are you drink?
The question is, can you take duloxetine and Aricept together? And if so, can you have a cocktail? You want to take that one, Daryl?
Sure. Yes, you can take those two together, but they have to be monitored. And taking a cocktail with any of these medications is actually a little bit risky. A lot of people will go ahead and try it. If you talk to your physician, they'll say no. Mark, I know, has had a cocktail throughout the world. And as a physician, how would you approach that?
I would want to have a lot more information that I think is appropriate to discuss in an open forum like this in terms of your confidentiality as to what exactly you're taking these two medicines for, and then as we said earlier, risk benefits. Do the risks exceed the benefits, or vice versa? So, it's not our role here to do individual counseling of, I'm taking this drug. What should I do? It's more of a, that's between you and your physician. So our role here is just to educate you about these general classes of drugs.
In researching on AI, that's what caused me to ask the question. Is I was just looking up different medications and what the interactions are, and the caution there, and maybe it's a caution about using AI in conjunction with your physician, of course. But anyway, is that duloxetine used with Aricept has the potential for causing night thrashing and things of that nature. Can you answer that just in general terms?
I'm not familiar with that specific side effect, but I do want to address AI.
Okay, good.
In a more generic term. AI can be incredibly helpful. It can also be wrong. I use an AI program which you folks don't have access to. It's a professional AI program for medical professionals. And I found errors in it. When I've used it to research subjects and then gone back to the references and found that it has misquoted the references in ways that are just wrong. It said reference A said B, and when I looked at reference A, it actually said C. So, and they say this is a specific medical AI program, which I would think would be more accurate than ChatGPT or Gemini or something like that. And even here, I found errors. So be cautious of AI. It's helpful. I use it a lot, but I don't take it as absolutely foolproof. It isn't. And in the non-medical AI world, I would expect that there will be even more errors than in the program that I use. I don't. Yeah, I'm not I'm not a watchdog. Yeah, go ahead.
Very quickly, I want to give you my sleep pattern, and it's a little unusual. My younger brother, he's 5 years younger. He has the same pattern, and many people that I talk to. But anyway, my primary sleep time is I usually fall asleep at 9 or 10 o'clock at night, usually in my recliner, and in about 4 hours I wake up with just one light on. My wife has gone to bed. It's 2 o'clock in the morning, sometimes 3 o'clock in the morning. I can't sleep. I watch television. I read. I do things. I eat. And then that's the only short time. The rest of the day is just a hodgepodge, and I don't know when this came on me. I think it's been a good 10 years ago. But I'll fall asleep about 9 o'clock in the morning and sleep for a couple of hours and maybe catch a nap about 3 o'clock in the afternoon. It's just a hodgepodge. A lot of it has to do with how much exercise I get in between. And sometimes if I, the other day, last week I drove for 4 or 5 hours straight from Central Valley up here. I had no trouble staying awake. As soon as I got in the front door, I was out. I was exhausted. Could you make a comment about that?
Not really. As I said previously, our role here is not to take the place of your physician and tell you this is what you should or should not be doing in this specific instance. So, there's all kinds of reasons that this may be occurring, and it's not something that we really want to. Okay, well that's reassuring. But if you have not or previously done so, I would certainly bring it up with your physician at the time of your next visit and ask him or her what they recommend for you. In the back.
Yes, I have 2 questions. First question is the over-the-counter anti-inflammatory drugs. You did not mention Aleve. I wonder what your comments would be about Aleve.
Aleve is also naproxen, so it's just a different salt form of the drug. It's a sodium salt instead of a hydrochloride salt. It's an effective drug, but it has the same side effect profile as you would.
So it would have the same profile as Tylenol PM?
Tylenol PM has Tylenol and Benadryl in it. So
Does it?
So it's a different class of drug. But the non-steroidals like Motrin, Aleve, they're very similar.
Second question. My wife has A1 diabetes. Are there any drugs that would interact with her diabetes that you're aware of that cause a reaction or risk?
Well, actually, there's a lot of drugs, and you'd have to, there's a whole list of drugs that can do that. Also, herbal medications can interact with diabetes, so you have to review that with your physician or your pharmacist if you're looking at that kind of thing.
On the same note, really, I'm also diabetic and am cautioned against vitamin C, and I'd like to know the relationship between vitamin C and raising your blood sugar.
Vitamin C, I'm not really aware of that interaction. And especially in low doses of vitamin C, like in a multivitamin, it's very safe to take that. Oh yeah, yeah, there is. I mean, some of those cold medicines they'll have like 2 to 3,000 milligrams of vitamin C, and that can be like airborne. I think is one of them, and that can be problematic. And it can be. I don't know about diabetes, but like if you're on warfarin, that can be contraindicated for somebody that's on warfarin taking that much vitamin C. So, once again, speaking to your physician and to your pharmacist would be super helpful.
And I would add that
Like I said, I'm really not aware of that.
and nor am I, but what I would add is that the evidence for the efficacy of vitamin C in treating an upper respiratory infection or a cold is at best weak evidence. When I get a cold, I don't take vitamin C. When I was in practice, I didn't recommend it to my patients because the evidence is very weak.
I'm a metformin using diabetic, and I've often wondered if there is a better reason to advocate for using an Ozempic or a Mounjaro. Is there ever any highway off of metformin and onto a different type of diabetic medicine?
I'll start with that. First of all, metformin is quite effective. It's relatively safe. That being said, the GLP-1s that you talked about are also very effective. They work in diabetes probably in two different ways. For those patients with diabetes who are overweight, the weight loss that they engender helps control blood sugar. But even independent of the weight loss, there appears to be increasing evidence that the GLP-1s decrease insulin resistance, and therefore they work in treating diabetes in two different ways. So yes, they're good. Again, as we keep on saying, these are decisions between you and your physician. If you're on metformin, you're doing well, and you're not having side effects, probably not a good reason to change.
Part two,
Go ahead.
hydrochlorothiazide.
Hydrochlorothiazide.
Yes, there you go. You know it better than I do.
Yeah. That's a mouthful.
Anyway, I play pickleball 4 or 5 mornings a week, and it's hot out there. And if there was something I could take in an alternative to that, because that's the one thing that makes me so sensitive to heat, I have to quit playing if it's too hot out.
Interesting. I'm not familiar with it being, causing heat sensitivity. On the other hand, I assume you're on it for high blood pressure, hypertension, and hydrochlorothiazide is a very effective and quite safe medicine for treating high blood pressure. But there are numerous alternatives, which are of different classes of drugs that would be worth exploring with your physician. Say, this makes me really heat sensitive. What alternatives are there? One in particular for patients with diabetes and hypertension are drugs called ACE inhibitors. And the reason when I was in practice, the reason I like to use them in patients with diabetes is that in addition to effectively treating high blood pressure, they also reduce the risk of diabetic kidney injury. So it's kind of a 2-for-1. Now, like all drugs, they have their own range of side effects, but that would be something worth exploring with your physician as to whether there's something that's better for you than the hydrochlorothiazide. The brand, first of all, it's been a drug that's been around for about 50 years. So it's people call it HCTZ, and the brand name is Esidrix, isn't it? But I don't think I ever see it referred to as Esidrix because it's been a generic for at least 50 years.
Been a generic longer than I've been a pharmacist.
Yeah, and when I started in medicine over 50 years ago, that was it was already a long time use for treating hypertension. It's been around forever, and it's cheap. It costs, I think, about 10 cents a pill. Yeah. You would probably know it as HCTZ or hydrochlorothiazide. I don't even know if the brand name is even being marketed anymore because the generics are so cheap. There's nothing in it for the pharmaceutical industry to put money into the brand name. Different, yeah.
That's an herbal reference.
The FDA actually has a website for herbal medications, and that's pretty reliable. And then the other thing is you can actually go on a drug interaction, drugs.com or whatever, and put in for drug interactions. And a lot of times they'll do herbal interactions on those websites.
Drugs.com?
Like drugs.com or WebMD. They have interaction programs in those sites.
This one asks.
Alternative for sleep, but I thought I had heard that maybe melatonin can cause dementia.
That I have not seen. Mark might know more about that.
I'm not familiar with that, and I hope that it's not the case because when I travel for jet lag, I don't use it on a regular basis, but certainly when I travel and have jet lag, I use melatonin, and that's new to me that it might cause dementia. Yeah, no, I'm not familiar with that. I certainly consider melatonin to be a pretty safe drug. Again, keep saying there's no such thing as a drug with zero potential side effects, but melatonin is pretty safe. In the back.
Wait.
You're not on.
Now I'm on.
Now you're on.
Sorry about that. I'm on a water pill,
Diuretic, yes.
that one.
Yeah.
And but I was also prescribed a statin, which I'd taken before, didn't like, and I was given it was based on some number that is a calculation of all of my information.
Your cardiac risk factor.
And then I went on AI and did research, and AI said, well, that's an older version. There's a newer version of that. And I ran the new numbers, and then I went back to my doctor because I didn't want to, like you say, you can't just trust AI. And she looked at it all, and then she changed she didn't prescribe the statin. So it looks like information is changing on statins, and I was kind of hoping you would talk about that a little bit if you're up to date on that.
I take a statin, so yeah, I'd say that I'm up to date on it. Statins are pretty safe drugs. They've been around now for about, I would say, probably 30 years. We've been using them. They have a good safety profile. Again, not perfect. And there are, in the cardiology literature, there's a lot of thought that there's no such thing as having an LDL, low density cholesterol, the bad cholesterol. There's no such thing as having an LDL that's too low. That the lower you get your LDL cholesterol, the lower is your risk of cardiovascular events. So there's a school of thought that says that everybody over the age of 65 should be on a statin. I don't really buy into that, but I think that the threshold for prescribing statins in our age group is pretty low.
Changing diet and increasing HDL and decreasing triglycerides dramatically that was what I did. And I was wondering if so that's still not as good as lowering LDL.
Not necessarily. If you get your HDL up, actually the best way to get your HDL up is through exercise. But if you can do it with diet and exercise and lifestyle modification and not take a drug, that's better. Almost universally, I would say if you can make lifestyle changes and avoid taking an over-the-counter prescription drug, you're better off. There are, as far as I know, no adverse effects of exercise other than a sprained ankle or something like that.
That would be my goal, is to constantly, but I'll always check it. I'll always go back and ask the doctor.
Yeah. With drugs, less is better. Almost universally, less is better. Any other questions?
I have a question. What are the drug combinations that you most see causing problems with older adults?
You're talking about drugs or drug combinations?
Drug combinations.
Take that, Daryl.
So most in older adults, it's mainly like what we went over, the sedative and hypnotics, and then the sleeping medicines, and then also combining them with the anticholinergic medications. Those are probably the biggest things in the older adults because we just don't tolerate them as well. And so things that we might have done in our 20s, 30s, 40s, we react differently once we get in our 60s, 70s, and 80s.
Are there any other questions? All righty.
Thank you very much. Thanks for being here.
Yes,
Yeah,
thank you.
you.